What's up, you guys? My name's Miguel, fellow Xray Tech here, giving you your daily dose of radiation. In today's video, we are covering the protocol for a G2 Mickey button. Like, there's different names to call it, but essentially it's a tube that goes into your stomach that they use for feeding. And essentially, in our field, if it's done just like in the emergency room, or it's done, they just want some contrast injected into it, which there's different kinds of contrast. You have to, there's a set protocol. So to give you context, I am a night shift X-ray tech. I've been doing it for about 4 years. And usually the people who get this are either little babies. Majority of the times you'll have a few adults that are, I would say, normal that have them, but majority of the time it's older people who are, maybe they had a stroke and they're contracted, or Truman Smith. They're a little bit different. They're not typically, we see that a lot. I've noticed that in my 4 years of doing this. So it's pretty easy. You go in and you do a regular KUB, so like an upper KUB. You can see where the tube is on your scalp. As long as you see the tube, that would be good. You use the first one as scalp, and then you can get a little cup. You can either do 1 cup, 2 cup, whichever one you want, depending on what resources you have. But essentially, we use gastrographin. A small bottle will do. I know some places only have the big bottles. I mean, you don't really need to use all the bottles. And then you have a syringe. Depending on the type of like entrance that they use. I know some of the babies have like the Mickey tiny ones. Those use like the purple like screw on top. And other ones use the big like long needles that will go inside the tube, and then you inject the contrast. So you just got to pay attention before you start, injecting the contrast into it. I mean, probably a good 30 cc's of contrast. You'll inject it, and then you'll like shoot the patient, and then you should be able to see the contrast like inside. If you're in the right spot, like you should see like come in, and usually that's all you need. We'll look at it. As long as you have contrast in there and you see it, then you're good. Then you send it off to the rad or the emergency room doctor, whoever, and you should go on from there. And then afterwards, you get like some water that's about mid or body-ish room temperature, and then you inject it again just to clear out all the contrast, make sure you don't have anything going on, and make sure that you close it back off. Sometimes you got to be careful. Certain ones, more on like the babies, they'll have a clamp, and if you're trying to inject contrast and there's a clamp to it, you're gonna have like resistance and backflow, so you have to make sure of that. Always double check that the patient's not allergic to contrast. Usually they're not, if they already have that, but at the end of the day, it is our job as X-ray techs to be on top of that and make sure that we know what we're doing. You have to charge for contrast. That's not pretty hard, depending on your area you have. Like your hospital, they have their own protocol to how to charge the patient for contrast. And you put the dose in whatever contrast you use, gastrographin or whatever. And then that's pretty much about it. When the order comes in, it's just like a regular KUB. You just have to look into the descriptions of where the doctor ordered it. It'll be like for placement of this, like the G tube. And then let's say like with contrast or with gastrographin, or whatever type of contrast you use for that at your hospital. There's different kinds. I would say that's like the most amount of fluoroscopy-ish, if you even count it, we do at nighttime involving contrast. Whereas that one I don't mind. It's pretty easy. Just inject some, take a picture, keep it moving. It doesn't take too long. Now, The only issue you could kind of run into is these patients being contracted and being not in the most optimal position. You may have to like angle the tube, roll them over, have it in certain angles, because there's been times where you have patients that like they're contracted to the point where it's like covering or be like overlapping where the tube is. So you may have to do some adjustments. Or there's been a few times where I've had to hold the patient and kind of move their arms and have them turned in a way just so we can get optimal images, because obviously if like he's turned all the way to the side and you shoot it like with the gastrograph, and it's not gonna like the radiologist won't be able to get the optimal read. And especially if there's motion or if there's anything, the radiologist sometimes drags you back, and then like it'll like on the report it'll say sub image quality recommend doing it again, or recommend more contrast depending on what's going on. Now sometimes, this is the hypothetical, sometimes the patient will have a situation where they kind of pulled at their tube and or maybe like kind of ripped their tube. There's been one time where the little like tip of it was cut off, and we just looked at it and we're like, what are we gonna do? Usually they do a full replacement. It was like chopped off, like the little thing that we connect the tube to, like to inject the contrast. And the doctor was like, well, we just want to make sure it's still in the right spot. We can just connect an adapter to it. And I was like, I never knew that was an option. And essentially we had to get some kind of like tiny syringe to inject the contrast into. That was the most completely different outside of the norm that I've done. And I mean, with the babies, once again, you'll use less contrast with the babies, obviously, because they're tinier. It takes like way less, like you probably maybe 10, 15, depending on how big they are, cc's of it. But it's not that hard. It's like, it took like one or two, like looking over the process to be like, okay, this is how it's done. And I mean, it's not that bad compared to like it. I don't like fluoroscopy. There's other rads who do. I don't enjoy that. That's why I work nighttime. But that's like the most, so that's the okay one. Yeah, it's been your boy Miguel. We'll see you on the next one.